Good. Hello, everyone. I'd like to welcome you all to our PERFORM and Diamonds EU Grant Study Day. My name's Mike Levin. I'm a pediatrician at Imperial College London, and I have the privilege and the pleasure of coordinating the PERFORM and Diamonds EU grants. So I'm going to just say a few words about Diamonds and PERFORM. The PERFORM grant was launched in 2016. It runs until the middle of next year and is an 18.5 million euro award with partners in 9 EU countries, the Gambia and Nepal and Taiwan. And PERFORM led to and overlaps with and is very much the plank on which the Diamonds grant was awarded. Diamonds is a 23 million euro grant with partners in 11 EU countries, the Gambia, Nepal and Taiwan, and kicked off in January of this year and will run for 5 years. And I'm really speaking on behalf of this wonderful community of pediatricians, scientists, laboratory workers, nurses, informatic experts, computer technologists and engineers who have worked together now for about 15 years on different EU projects. And we are immensely grateful to the huge support. This would not be possible without the European Union's supports. To begin with, I'm going to try and explain a few words on why we need a new approach to the diagnosis of infectious and inflammatory diseases, because PERFORM set out to deal with the more limited problem of how do we distinguish bacterial from viral infections, and Diamonds takes on the much wider problem of how do we come up with a new way of diagnosing and classifying all infectious and inflammatory diseases. So first of all, who are the consortium? There are partners in the UK with multiple hospitals and universities. I haven't got time to mention them all. Switzerland, Netherlands, Germany, Spain, Greece, Slovenia, France, Austria, Italy, Latvia, and we also have partners in Nepal, Gambia, and Taiwan. So this is really a huge consortium spanning much of Europe and beyond. And the start of all this collaborative work was the very real problem of critically ill children with fulminant bacterial infections like meningococcal disease. And really the whole reason that PERFORM developed, that our consortium developed, was the need for better diagnosis. And it's illustrated graphically by this terrible image of a little child who came to an accident and emergency department with a fever and was looked at by a team of doctors who said, this child has probably got a viral infection and they can go home on symptomatic treatment. And a short while later, the child returned critically ill with fulminant meningococcal disease. And a parallel problem is that we have children brought to pediatric centers, to accident and emergency department with fever. This child presented with 10 days of fever, had already seen the emergency department and general practitioners on several occasions, was given antibiotics in the thought that they were suffering from a bacterial infection. And 10 days later, Kawasaki disease was diagnosed. This disease leads to damage to the coronary arteries. And this could have been prevented had the disease been diagnosed early. So the problem we face as pediatricians, and it's also a problem for adult medicine, how do we recognize the rare patient with a severe fulminant bacterial disease or inflammatory disease amongst the infinitely larger numbers of patients with self-resolving viral infections? And we are faced with the problem that microbiological culture, which has been the basis of diagnosis, is slow. We don't get results for 24 or 48 hours. And as a result, many patients undergo treatment with antibiotics or undergo invasive investigations, lumbar punctures, blood cultures, urine cultures, chest x-rays, trying to find the cause of infection. And others are sent home with the label that they're suffering from a virus disease and later become critically ill. The scale of the problem is immense. Fever is one of the commonest reasons that children are brought to their family doctors in the community, and almost all children will have a number of episodes of fever per year, but only a tiny proportion of them are caused by severe bacterial infections. At a hospital level, we know that 25% of all attendances of children are caused for fever, and of these, only between 3 and 5% will be diagnosed as having a bacterial infection. And yet, as you'll hear later, a high proportion will receive antibiotics. Amongst children who are sick enough to undergo blood testing, only about a quarter will end up having a bacterial infection, and yet very high numbers are given antibiotics. And then at the tip of the iceberg, we have the patients who were not diagnosed in time and end up on our intensive care units or fatal because no one thought in time to start antibiotics. Our previous EU study, Euclids, which finished in 2016, recruited 4,600 children across Europe and made a very vigorous effort to establish which patients had a definite bacterial or viral infection. And the really amazing result, which was published in The Lancet in 2018, was that we could make an accurate diagnosis in 1/4 of the patients, but the remaining 3/4, there was no clear answer as to whether they were suffering from a bacterial infection, a viral infection, or an inflammatory disease. So we really need something better. And culture, which has been the mainstay of diagnosis of bacterial infection ever since Louis Pasteur, we know is slow, it's insensitive, as I've just shown. Molecular pathogen detection, which has exploded as a rapid means of detecting viruses, has been extremely successful in rapidly identifying pathogens, but has not helped greatly in excluding bacterial infection, as you'll hear later this morning. So the problem that we face in hospitals across the world really is when a patient presents with fever and looking unwell, which patients should we undertake invasive investigations, who should get antibiotics in order to avoid missing a small number with severe bacterial infection and perhaps prevent progression of infection. And the converse of it is that the vast majority of infections are viral. Most will not benefit from antibiotics. And we are suffering from a huge explosion of antimicrobial resistance, and there is a huge cost to society. So what PERFORM set out to do was to ask, can we come up with a better way of distinguishing bacterial and viral infection? Is there an alternative approach? And rather than attempting to identify the pathogen, can we identify the host response to the pathogen? And the underlying hypothesis is that each pathogen triggers a specific host response that can be used to identify the pathogen. And this really is a paradigm shift which has taken place over the last 15 years. We, rather than trying to find the pathogen, we have the idea that each pathogen, a bacteria or a virus, will activate the host inflammatory system. Genes will be switched on and proteins will be switched on. And those that are switched on by viruses will be different from those that are switched on by bacteria. The basis of the work started with the development of means of rapidly recovering RNA from blood. And so this cartoon highlights that we can take a blood sample, just a ml or 2 of blood, and this blood will contain all the genes that are activated during an infection, as well as all those that are switched off. And it's proved to be a remarkable tool for research, because all you have to do is take the sample and put it in a freezer, and it can be analyzed later. And from the blood, we can recover the RNA. And the tool that we started using about 15 years ago was the genome-wide array trips that were becoming available in the early, just after the turn of the century. And this is a picture for those that haven't seen it. This is a glass slide. Each channel has thousands of little dots printed on it. Each dot is the sequence of a gene. And if you magnify them, you can see when we put the RNA from a patient onto the microarray slide, those genes which are activated are seen to glow brightly, and those that are switched off will be darker. And by analyzing this, we can get a snapshot of all the genes in the human genome which are switched on or switched off. This was the early technology. We're now using RNA sequencing, which you'll hear about later in the day. We first began applying this technology in a Wellcome Trust supported grant, linking Imperial College, Stanford University, who were then the leaders of RNA technology by microarray, and the University of Cape Town. And we undertook a study which compared patients with tuberculosis, patients with meningococcal disease, patients with malaria, and patients with other sources of fever. And what we did was recover the RNA from each patient, put them onto a gene microarray, and each column is a patient, and each row is a gene. And if the gene was switched on, we have a red color. If it was switched off, we can have a green color. And when we first saw this result nearly 15 years ago, it was, to me, the most amazing finding, because all of these patients were virtually indistinguishable by the pediatrician. They were all sick, they all had fever, they all looked unwell. And yet what you can see, I hope, from anywhere you are, is that the patients with tuberculosis had hundreds of genes which were red, which were green in the other diseases. And here is a whole region of genes that were green, so switched off genes, which were red in all the other diseases. And what this suggested to us is that gene expression looks better than clinical judgment in diagnosing the cause of fever. And this single experiment, 15 years later, this was the seed that led to PERFORM and then to Diamonds. So over the last 15 years, we've had a journey in trying to apply gene expression technology to the study of different diseases. And first, with the support of the EU, we received a grant to study tuberculosis. And this led to the publication in 2014 of a gene signature for childhood tuberculosis in patients in South Africa, Malawi, and Kenya. And this was a huge collaborative effort. We then applied it to the distinction of bacterial and viral infection through a study called IRIS. And this showed that we could distinguish bacterial and viral infections with a small number of genes. And this led to the PERFORM grant, which we'll be talking about. We also applied the technology to inflammatory diseases and showed that we could distinguish Kawasaki disease from other diseases in a paper in the Journal of the American Medical Association in 2018. And the PERFORM grant, as you'll hear, has led to a much broader concept, the Diamonds grant, where not only can we distinguish bacterial from viral or TB from other diseases, but we hope to make a new classification of all infectious and inflammatory diseases. So PERFORM set out to evaluate these promising new genomic and proteomic methods in 5,000 patients, which we had already recruited in the previous EU grant. We aimed to validate the performance in the prospective cohorts, but also to prospectively pilot the most promising transcriptomic in a new cohort of febrile patients across Europe and West Africa. We also aimed to evaluate the performance in immune-suppressed intensive care, critically ill patients, and inflammatory diseases. To pilot the most standard approach to the management of febrile children, to develop a management algorithm for febrile patients and evaluate its performance in different European countries, to undertake cost-effectiveness analysis to work out, will this new approach be cost-effectiveness for healthcare centers, and to develop a device in collaboration with industry and small and medium-sized enterprises to detect the new diagnostic device, and then to disseminate the findings to European countries and the wider world. So I'm not going to give any details of this because it will be dealt with in the different talks in the rest of this morning, but really that the efforts to identify biomarkers for diagnosis are absolutely critically dependent on having a gold standard of carefully defined patient phenotypes. And what we've done in PERFORM and will happen in DIAMONDS is febrile patients were recruited as they arrived in hospitals around Europe and our partner countries. Every patient then was, based on the clinical features, separated as to whether they looked like a bacterial infection with conditions such as sepsis, cellulitis, pneumonia, urinary tract infection, a viral infection with features of a viral-like syndrome, the patients that didn't easily classify as bacterial or viral, and then patients that turned out to have inflammatory diseases. The patients went through a very detailed clinical investigation utilizing all the results of bacteriology, virology, hematology, chemistry, and investigations. And we could then classify the patients as to whether we had a definite bacterial infection, a definite viral infection, patients that we couldn't really classify, or whether they had inflammatory disorders. And this very detailed phenotyping, I think, is unlike many other attempts to identify biomarkers of bacterial infection, because we have the gold standard of culture-confirmed bacterial infection and definitely excluded viral infection. So today's talks will report on key aspects of the work of the PERFORM Consortium. You'll hear a description of all the patients recruited from Federico Martinón-Torres. You'll hear an analysis of over 38,000 patients attending emergency departments. You'll hear our attempt to develop new diagnostic approaches for both RNA and for protein, and how we've attempted to translate this into a diagnostic test. And finally, we'll hear the attempts to analyze how a new method for approaching diagnosis will influence cost effectiveness and social aspects. I'm going to end by saying a few words about DIAMONDS, which will not be really talked about greatly in this symposium because it's only in its first year. PERFORM laid the ground for DIAMONDS. DIAMONDS uses the same cohorts, samples, and phenotyping, as well as the lessons we learned in PERFORM, and also will be recruiting a new cohort of over 5,000 patients. But DIAMONDS goes beyond simply trying to find a biomarker to distinguish bacterial from viral infection, is it attempts to approach all infectious and inflammatory diseases. And the idea is, whereas the conventional diagnostic approach is to examine the patient and listen to the chest and examine all the clinical features, to use the results of all the laboratory tests and scanning and imaging, and eventually try to reach a diagnosis. Whereas diagnostic classification using the International Classification of Diseases is based on all the clinical and laboratory features, DIAMONDS proposes to develop a new molecular classification of diseases where each patient is recognized by the patterns of genes and proteins in their blood. So Diamond will recruit 5,000 subjects. It'll undertake RNA sequencing on new patients, as well as the many patients already recruited and sequenced during PERFORM. The samples will be analyzed, cleaned, and then placed in a European transcriptomic library. We hope to develop an open access resource for scientists all over the world by depositing the expression data of all the different diseases in a European library. And in addition, we hope to include external data sets for diseases that we might not have actually recruited. You'll be hearing later in the talk from Myrsini Kaforou on how we have moved beyond the simple attempt to distinguish bacterial from viral diseases in a binary classification during the course of PERFORM to a multi-class approach which hopes to be able to distinguish not only the infectious diseases, but inflammatory diseases and potentially cancer using the signature of each disease. And we hope that this European transcriptomic library, which will have all the major diseases with their RNA expression data available, will then be able to be used to find the smallest signature, which will classify each different disease, resulting in a new taxonomy of disease. So I've attempted to give you an overview of really a research program that has been in progress for many years and is going on over the next 5 years. And I'd like to end by saying that I've been talking on behalf of an amazing group of collaborators, the collaboration across countries and within countries that has developed over the course of PERFORM, following the previous Euclid's grant, is a tremendous example of the benefits to science that we can have by pooling our expertise in different areas, by working across the expertise in different research laboratories, and by pooling the clinical resource of patients with a whole range of different diseases. And of course, the work is only possible because of the huge support we've had from the EU in supporting the PERFORM and Diamonds, and before that, the Euclids and TB consortium. So I'm going to end by passing over, I'll stop the sharing and pass over now to Federico, who's going to describe the clinical cohorts on which PERFORM was based. Over to you, Federico.
Thank you very much, Mike. You should be now seeing my screen, and I'm also delighted to participate in this symposium that is, as you have already clearly expressed, the result of a fruitful collaboration across the last years of an amazing human group working with the same target with the help of the EU funding. And I'm so glad and proud of being part of this amazing consortium. So in the next minutes, I will describe the first ingredient on this puzzle, which is the clinical picture of what are we doing currently in the management of febrile children, and what exactly are the characteristics of these patients, and how are we actually taking care of them. Mike already specifically expressed that the febrile children is the combination of a specific pathogen or combination of pathogens and a specific host. And as a result, we see different phenotypes, clinical phenotypes, that in the early stages of a febrile child are very vague clinical syndromes. And we also know that the different outcomes that you can expect with the different combinations of these pathogens and a specific host. So the first step in the PERFORM study was to really describe the different phenotypes and the characteristics of these different phenotypes according to the pathogen and to the clinical recognition in the initial assessment of these patients and the eventual course of the disease in each of the recruited subjects. For that, we need we needed a huge effort. I would say that unique effort based on a strong consortium with different countries, not only across Europe with more than 11 different countries participating, but also with the collaborationship of centers in the Gambia and also in Taiwan. So a full multi-country international consortium that were working all together with the same target to really tackle with the problem of febrile children. For that endeavor, we needed different specific subtasks, and I will be talking specifically about the prospective part of the recruitment, what is called the VIVA studies, that in a minute I will describe in detail. The organization of this very complex study needed, of course, the participation, as described, of several partners, several sites, and with the importance of all of them, from the different leads of the different sub-studies, as you can see in this slide, that played an amazing and major role in the clinical design and development of the PERFORM study, but also all the nurses, all the clinical researchers that participated, and of course the collaborationship of the children and their families by participating in our study. So the clinical, the PERFORM clinical network design a prospective study in order to collect any sort of febrile children and try to describe in detail the characteristics and to collect a rich full set of samples to do also not only the clinical assessment and the clinical phenotyping of these patients, as I will describe in this presentation, but also to do the molecular phenotyping, as we will be seeing later in other colleagues' talks. So these prospective studies called VIVA studies included on the first part what we call the VIVA ID study, that was looking specifically for children, any sort of children with ill appearance, with fever, attending to the emergency departments, and with an original aim of trying to recruit up to 3,000 of these children in our study. Then there was another sub-study within this VIVA umbrella, that was the VIVA PEAK, specifically aiming for children admitted to the pediatric critical care unit, and with the specific aim of collecting 500 children. Also, we included the VIVA high-risk patients, the immunocompromised patients, with the aim of being able to recruit at least 200 children. And finally, we also tried to include inflammatory and rheumatological patients, up to 200 children. So as you can see, we are looking for children with fever, but with any origin of that fever, not only or exclusively fever related to infectious diseases, but all other possible entities that might cause fever, or fever not only in previously healthy children, but with underlying conditions. Well, I think it's important to outline the difficulty of this study, because as it has been said in this first 3-4 minutes or 3-4 slides, it might seem a simple task, but it was not at all. The commitment required for each of the participants of these studies was huge, because the comprehensive data set to be recovered for each of the participants of each of the recruited subjects, together with a very complex sample set that was going to be collected in a serial approach. So not only upon admission into the study or to the arrival to the emergency department, but also in a sequential order in later visits. So after 24 to 72 hours, or in the convalescence phase also. So serial sampling on these patients can give you an idea of the complexity of this clinical study. On the top of that, we were also requesting to do a very careful clinical phenotyping based on our routine clinical practice, on what we actually do in a daily basis in the management of these febrile children, but trying to organize all these patients into the best possible clinical categorization. So near to what we do in real life, but in a, let's say, reproducible manner. For this purpose, we use the scale you are seeing in this slide that we have previously used and is already published in different important papers, like in the JAMA or in the Lancet. And we have been using before to try to establish this, let's say, clinical categorization to later on be able to compare these clinical categories with the molecular phenotyping. So I think this is important, and this is a collaborative effort, but led by Jethro Herbert, that you will meet him later on, and was the smart mind behind this very important part of our study. Also, we applied very stringent quality controls to ensure that this was not only collecting patients or numerous patients, but also that each and single patient recruited into the study had very high quality standards in terms not only of data entry, but in terms of sample collection with very specific SOPs, with very specific tracking systems, and it has been achieved through specific quality control plans and with the collaboration of all the clinical partners, but also all the lab team, because we are talking not only about thousands of patients, but thousands of samples and aliquots. You can see here Irene Riveri enjoying doing this quality control with some other colleagues of the group, just kidding. Okay, so the number of patients that we actually recruit in PERFORM was impressive, as you can see in this summary slide. We were able to collect over 7,000 children, fulfilling the inclusion criteria of having fever and being able to be included in the study, in the VIVA studies, in any of these VIVA sub-studies. This included also control patients, which was also essential for the aim of our study. And it also included a specific Nepali cohort with children with pneumonia. If we look at the breakdown of these patients according to the studies, we finally were able to include in the emergency department sub-study above 6,000, so 2 times the original aim committed with the European Commission. We were able to recruit more than 700 patients admitted to the pediatric intensive care unit. So again, far above the original target agreed with the European Commission. In the terms of the high-risk groups, we tripled the numbers, and we went up to 600 patients included with immunocompromised or high-risk conditions, and up to 217 patients in the rheumatologic group. So in terms of numbers, a really significant effort with impressive results. You can see here also the breakdown according to the different countries, with an impressive effort in all the participant centers and partners, considering that some of them with lower numbers, it's also true that they were included in the consortium and clear to be able to recruit later than the other centers. So this is the description, and as you can see, there was a huge setup to be able to do this study and a huge commitment of all the participants. And because this was essential to describe the state of the art, what are we actually doing and seeing when we talk about children with fever. And now I will describe you the main characteristics of this recruit cohort. As explained, most of our patients were included in the VIVA-ED study, the study related to the emergency, the patients attending to the ED, and you can see the breakdown for the other sub-studies. And these are the characteristics of the samples. You can see that 16% of our patients were below 1 year of age. And as you can see, the majority of our patients were below 2 years of age. You can see also the gender distribution. When we look at the inclusion criteria, you can see that most of the patients actually had a combination of 2 or more of the inclusion criteria shown above. These are the numbers that were specifically presenting only one of these inclusion criteria, which was the history of fever. documented fever upon attendance, or the suspicion of an infection. But as said, most of them had a combination of 2 or more of these inclusion criteria. When we look at the characteristics of the cohort, it's important to outline that our patients, look here, and this is very important, were recruited in the vast majority of them very early on the course of their disease. So the duration of symptoms before they attended to the ED and were recruited in PERFORM, in half of the patients were before 3 days course. So we have a prospective collections of patients and samples very early in the, because it reflects the doubts we actually have when dealing with our patients in the very early phase of the disease. You can see that some of the patients have been already seen before and some transferred from other centers. And in terms of triage, as you can see, they were very urgent patients in almost 40% of the cases, and life-saving interventions were required only in a few subset of the included patients. But I think it's important also to outline that 1 out of each 3 patients had an ill appearance at presentation to the emergency department. Well, another important aspect is the comorbidities. And you can see here the breakdown of the different comorbidities collected in our study and the frequency of these comorbidities globally in our cohort. Also, as part of the collection of data, we address also or specifically outline those comorbidities or medications that might eventually increase the risk of an infectious disease. And 7% of our patients fulfill either of these 2 criteria. If we look at the breakdown of these comorbidities, and here you can see each of the comorbidities collected, the categories of comorbidities collected, and in the columns, the total cohort, the ED patients, the PQ patients, the inflammatory patients, and the high-risk patients, you can see that the prevalence of these comorbidities varies, as we could expect, with the highest percentage of comorbidities as it could be expected in the high-risk groups, in the immunocompromised groups, but also interestingly, in the PQ patients goes up to 6%, so 10 times higher than the patients just attending the emergency department. But this percentage of comorbidities is even higher in the inflammatory patients cohort. The predominant ones, as you can see here, were the pulmonary and the prematurity and the neurological ones, and also the foreign bodies understood like catheters, etc., in those patients that were included in the PQ cohort. For the inflammatory patients, gastrointestinal comorbidities were present in up to 15%, and it was the most frequent one comorbidity detected in this group. And of course, in the high-risk group, as we could foresee, 55% showed an underlying malignancy, and 41% had a central line or a reservoir or any other foreign body that might explain or contribute to the risk of infection. In terms of working diagnosis, and this is a diagnosis that was performed in the sites, it's, let's say, the regular or the routine practice that is applied in each of the participant centers. So this is not control, or this is not part of what we are aiming in our study. We are just making a high resolution video, because it's not just a picture. We are making a follow-up of these patients, where we are making a high resolution video of children with fever, but we are not interfering in what is being performed in these patients. So this is important because in this slide, you can see summarized the different working diagnoses. And as you can see, 1 out of each 3 patients attended in the emergency department receive a chest X-ray with pathologic findings in half of them. Urinalysis was the most frequently performed complementary exam in 44% of the patients, but with the diagnostic yield much lower, with only 13%. In terms of lumbar puncture, you can see that 8% receive a lumbar puncture and 1/3 of the patients retrieve pathological findings. And the so-called rapid antigen tests that many in our series are actually strep tests, as you can see, has not a very wide implementation, and only 25% of these patients received this test, and only few of them had a positive result. When we look at the clinical syndromes, how these were classified, you can see that the predominant patients were lower or upper respiratory tract infections. And if we look specifically at which diagnoses were under these categories, we can see that in the upper part, tonsillitis was the most frequent phenotype. In the lower tract infections, pneumonia was the most frequent phenotype. In pathogen syndromes, the flu-like illness was the most frequent. Fever without source was very frequent in patients with just fever as a predominant sign. In those that we classified as others, the CLABSI was the most frequent one. In osteoarticular, osteomyelitis was the most frequent. In neurological syndromes, meningitis was the most frequent. Gastrointestinal diarrhea. In urinary tract infection was the most frequent in the urological nephrological syndromes. In the skin, cellulitis was the most frequent, and bacteremia was the most frequent in the sepsis syndromes. If we look at the distribution of these different syndromes according to the cohort, we can see differences that I think they are significant and are outlined in this graph, with a predominant in those attending the emergency department of lower respiratory tract infections and upper respiratory tract infections mixed here. And in the pediatric intensive care, again, respiratory syndromes were the predominant ones. Interestingly, in the inflammatory patients, gastrointestinal syndromes, not surgical, it should be gastrointestinal or surgical abdomen, but gastrointestinal syndromes were very frequent in the inflammatory group, and undifferentiated fever or other sort of infections was the most frequent clinical syndrome detected in the high-risk group. When we look at the phenotyping, the one I outlined that was an essential part of our study, probable bacterial syndrome, those unknown, probable viral or viral syndromes, definitive viral syndrome. You can see here that the predominant pathogens in both bacterial and viral. For bacterial, clearly you can see the predominance of E. coli and then the Staph aureus. And this is a significant change of the paradigm of pathogens as compared to those we found in the Euclid's era. Maybe outlining that the wide use of certain vaccines has really changed the landscape of pathogens. See also Klebsiella, Salmonella, and other pathogens that were less frequent in the previous Euclid's cohort. And in terms of definite viral patients, influenza and RSV together with enterovirus and adenovirus were the most frequent pathogens found. But importantly, and this is essential, and Mike already outlined that for the Euclid's cohort, and it's again with the PERFORM cohort, our capability to identify an organism, and green is the predominant color in all the different categories, as you can see here, is very low. And we are able to identify a pathogen in less than 1/4 of our patients. So this is the routine practice worldwide, or at least a European high resolution picture. And as you can see in gray, in the total the cohort, we were not able to identify a pathogen in 65% of the patients. So you can see a different distribution of identification of bacteria or bacterial virus, but the predominant color is gray. And this gives us an idea of how limited is our capability to actually identify a microorganism. And with regards to the comparison of our cohort, and specifically with the Euclid's one, you can see here different outcomes. So some of the patients required a new evaluation. Half of the patients that attended the emergency department required admission to ward. 5% were admitted to PICU, and only 0.8% actually died. If we look specifically to the most severe patients, or let's say those admitted to PICU that are more similar to the Euclid's cohort, we can see that in the PERFORM study, these patients were more severely affected in terms of death rate and also need of respiratory support or sepsis or septic shock diagnosis. And this is my very last slide. And it's an essential part of our work because we also address and analyze the rate of antibiotic use in adult patients. We know that antimicrobial resistance, as Mike already outlined, is an essential problem. It's one of the 10 major threats, global threats of the humanity in terms of health. And so we analyzed for the different phenotypes, what was the actual use of antibiotics? And we assume that indefinite bacterial, or even in those we might have doubt, the use of antibiotics might be appropriate, and it occur in 90% of the cases. But look, in viral syndromes, in probable viral, indefinite viral, or even in those with inflammatory conditions, we use antimicrobials in almost half of the patients. And according to what we know, in these patients, the antimicrobials probably don't have any impact, and we are using unnecessarily antibiotics in a huge amount of patients. So outlining again the importance of really making an adequate identification of those patients that have bacterial or viral infection, or even beyond, irrespective of the viral bacterial origin, which patients with fever do actually benefit of the use of antibiotics or not. And this is the true challenge of PERFORM and diamonds. So to conclude, antimicrobial use is extremely high in pediatric patients presented with fever despite the diagnosis of definite bacterial infection, which is confirmed in less than a quarter of the febrile illness consultations in the emergency departments, that despite the application of our best standards, a causative microorganism was identified in hardly half of the patients, that in Europe, 2/3 of the pediatric patients with fever attending the emergency departments are admitted to the ward, and that the redefinition of the clinical phenotypes of febrile children through a multi-omic approach constitutes the breakthrough solution for the management of the febrile children. And again, all my acknowledgements for the PERFORM and Diamonds family here in this picture. So this is what I wanted to share with you. And now it is my pleasure to hand over to Henriëtte Moll, that will give us very important details on the emergency department cohort. So Henriëtte, the floor is yours.
Well, good morning. My name is Henriëtte Moll. I'm a general pediatrician with a special focus on pediatric emergency care. And I'd like to present first result is more a snapshot of the MOFICHE study on emergency care in febrile children in Europe. And especially I present the data of our PhD student Doreen Bodenstein and Nienke Hagedorn. For the aims of the MOFICHE study, management and outcome of febrile children in the emergency department was to evaluate the management of febrile children in different European countries. And second, to study the determinants or predictors of antibiotic prescription, hospitalization, and diagnostics. And this study is a prospective observational study in 12 emergency departments in Europe. And we started data collection between January 2017 and April 2018. And we include children younger than 18 years of age. And they presented with fever measured at the ED or a recent history of fever, and we collected routine data. And as you see here, the population characteristics, we finally included nearly 40,000 children, and you see 16.8% had comorbidity, with a wide range in differences between the emergency department in Europe. 15% presented with an ill appearance, nearly 10% high urgency, and we get a large differences between emergency department that make the study very interesting. And 34% were admitted to the ward, a very small number, 0.4%, to the emergency care, and we end up with 4.1% of definitive bacterial infection, with a range from 1.6 to 11.2, and sepsis and meningitis is very rare, 0.8%. And I will discuss the main results on antibiotic prescription and some clinical results on prediction of invasive bacterial infection and some information about the adolescents. Are they more severely ill? Well, fever, we all know it's most common and mostly self-limiting, but we asked ourselves the question, how can we on clinical grounds define children who might benefit from new biomarkers? And we all know there's a large variability in antibiotic use between European countries. And understanding diversity is important to develop interventions to reduce antibiotic use. And our first study was published in PLOS-NET, and we looked at the variation in antibiotic prescription rate in febrile children in emergency departments in Europe. And as you can see here, the standardized prescription rates, the first column are the viral diagnosis, the mid column is the bacterial diagnosis, and the unknown bacterial and viral. And it was already shown in the two previous presentations how we classify these patients in bacterial, viral, and unknown bacterial viral. And we use the same golden standard. And as you can see, there is a large variability in antibiotic prescription in the different emergency departments. And of course, we adjusted for general characteristic, disease severity, like alarming signs and vital signs, diagnostic, and infection focus. So these differences cannot be explained by differences in case mix. And if you look in the category of bacterial infection, then you see that, well, we all agree that most of the patients do need antibiotics, but there is also variability in the category of unknown bacterial and viral. And if we go into more detail, then we look to what we call the appropriateness of antibiotic prescriptions. And likely appropriate is for all bacterial cases, likely inappropriate are the viral cases, and inconclusive is unknown bacterial and viral. So a third of all patients get antibiotics which might not be necessary. Of course, we know there are mixed infections, but it is a very low percentage, it's 1 or 2% of the viral cases. And we also look for appropriate duration in our prescriptions. And here again, 20% have an inappropriate duration. They get longer their antibiotics than needed. And the third analysis we did is looking for guideline concordance of oral prescriptions in respiratory tract infection. So this is a subsample of the total population of nearly 4,000 patients. And you can see that 22% get antibiotics not accordance to guideline. And the same we look for urinary tract infections, and also for 45 get antibiotic not according to the guideline. You get a different type of antibiotics. So there's a lot of room for improvement. So we asked ourselves the question, can we reduce antibiotic prescription in children at low risk for bacterial, lower respiratory tract infection? That is the most common infection in febrile children. And therefore, we used the Fever Kids tool, that is the decision rule, based on general characteristics, alarming signs, and vital signs, including CRP. And with this decision rule, we could identify children at low risk for a bacterial low respiratory tract infection and children at high risk, more than 10%. And we performed a study in the Netherlands, a cluster randomized intervention trial in ATDs for younger children, younger than 5 years of age. And we find that in low-risk patients, we could withhold antibiotic safely. And for the high-risk patients in this intervention trial, the usual care was given. So what would be the potential impact of this decision rule, which appeared to be safely in the Netherlands, at other EDs in Europe? So we simulate the potential impact of the Fever Kids tool on antibiotic prescription rate in children with lower respiratory tract infection in the European ED. And we again use our routine data. And as you can see here, we simulate usage, that is the application of the decision rule, and also the compliance. If the doctor used the decision rule, did he also follow the advice? And as you can see here, overall, it was 3.5% of antibiotic prescription. And you see, with a usage rate of 100% and a compliance of 100%, that's not real life, then we can reduce it with 23%. But if we go more to real practice, with a usage rate between 50 and 100% and a compliance rate of 90%, we could find a reduction of 8% to nearly 16%. And that was the simulation model, and we also applied the effect estimates from the Dutch intervention trial on the data of the MOFICHE study, and simulating the implementation, we get a reduction in antibiotic prescription of 9%. We got a reduction in all 12 European emergency departments, and we also saw that the impact in ED with a high antibiotic prescription rate was higher, and also there was a great impact in settings with a large number of low-risk patients. So now I come to the clinical part of my presentation, the prediction of invasive bacterial infection, and the question who will benefit from the new biomarkers. Well, we derivate and cross-validate the clinical prediction model, including CRP again, to identify invasive bacterial infection in febrile children. And we included all children with a CRP measurement. We excluded children with a urinary tract infection, as there is a point of care test available, so they don't need a prediction rule. And in the end, 60,000 children were included. The outcome was invasive bacterial infection, and it was a sterile culture growth of a single pathogen, so sepsis, meningitis, and osteomyelitis or arthritis. And overall, only 0.8% of invasive bacterial infections were identified in this cohort. And it also shows that this large cohort is needed to do feasible studies on this invasive bacterial infections, because otherwise you don't have power enough to do these studies. So we made a model, again, the Fever Kids tool I already showed you, but now for the outcome serious bacterial infection. We added abnormal neurological signs and non-blanching rash from the red alarming signs. They were not included in previous decision rules because they were not available in the study, so numbers are too low. It's again a profit of this large study, and we included complex chronic condition. So we were able to discriminate an invasive bacterial infection in 0.78, as they look of the curve 0.78, and we cross-validated it in the different emergency department with an area on the curve ranging around 0.80. So, what does it mean in practice? With this newly developed prediction rule, we could identify 34% of low-risk patients. We had a risk less than 0.1% for an invasive bacterial infection, and we could identify 6% of the high-risk patients with a risk of more than 2% of an invasive bacterial infection. And as you can see, there is the grey population, 60% of the population has an intermediate risk. So for this population, we need new biomarkers to identify and discriminate viral from bacterial infections. So we come to the last part, the febrile adolescent. Research and guidelines focus mostly on the young children, but we all know there is increased incidence and high case fatality rate of sepsis in adolescents. The aim of our study was to assess presenting signs and symptoms, the clinical management, and presumed cause of infection of these adolescents. And therefore, we performed multi-regression analysis. And we compare adolescents at an age above 12 years to the younger population. And if we look to the interventions, you can see adolescents has a higher risk of increased CRP. They get more often intravenous antibiotics, more often they were admitted. There were no difference between PICU admission, and they have more frequent serious bacterial infections, and also sepsis and meningitis is 2 times more often diagnosed. And of course, we adjusted the comparison between adolescents and young children for hospital, gender, duration of fever, previous medical care, and time of arrival and comorbidity. So to conclude about adolescents, there are differences in clinical alarming signs. I didn't show you that, but they are more presenting with general fever of ill appearance and abnormal vital signs, so the younger children more present with respiratory problems. They have more often diagnostic tests and were more often admitted and get IV antibiotics. So more often serious bacterial infections and sepsis and meningitis in the adolescent. So our take-home message is at the ED, inappropriate antibiotic prescription is moderate to high, so there is a lot of room for improvement. Implementation of the Fever Kids tool reduces antibiotic prescription with 8 to 50%. And the clinical decision tool identifying intermediate risk group for invasive bacterial infection in 60% of the febrile children. They might benefit from new biomarkers. And be aware of the adolescent. They present more often with sepsis and meningitis. So I like to thank the PERFORM partners for the contribution to the study and the partnership in working on this study. And my special thank to the MOFICHE partners who collected the data. It was not always easy, and to discuss the analysis and the final publications. Thank you for your attention.
So I think this is the time for Colin Fink.
Good morning, and thank you for letting me join. I'm the Medical Director of Micropathology Limited. We have been receiving all samples from both the Euclids, the PERFORM, and now indeed the Diamond study, and our molecular diagnostics, for which we already serve more than 200 NHS hospitals, has enabled us to provide a much greater insight into these pediatric patients, which have been collected from all over Europe. And we have been able to demonstrate some very interesting diagnostics in these patients in connection with the differentiation between viral and bacterial disease. And I would now like to hand you on to Dr. Mari Voice, who will give the detail of this and the work that she and her colleagues have been doing within our laboratory.
Hello and good morning from micropathology. So I'm delighted to be able to take you through some of the key findings from the work package 2, so the diagnostics work package. And these are really challenging a dichotomous view of diagnosing bacterial versus viral infection, and this has implications for how we test, treat, and manage patients in the future. So the aim of work package 2 was to perform a retrospective molecular screening exercise on all samples recruited into PERFORM, with the aim of providing each patient with a very detailed pathogen signature going forward into biomarker studies. So samples collected were processed at Micropathology. We're a specialist molecular diagnostics lab run by 29 postdocs with over 50 accredited molecular assays on our schedule. And once the data was collected, it was analysed in collaboration with our colleagues at Imperial College. So this is a workflow for all PERFORM samples received. We received throat swabs and whole blood samples. We then performed total nucleic acid extraction using a highly optimized Promega chemistry and an open platform Kingfisher robotics. Our swabs were analysed using a respiratory pathogen panel by Luminex, and the whole bloods were subject to an array of viral, bacterial and fungal PCRs, all of which were hydrolysis probe-based assays designed by our scientists in-house and run on 480 light cycler machines. So we took a pan-screening approach for PERFORM from the outset. So every sample received every test. So I won't list through all the targets, but on the blood side on the left, we screened for 24 bacterial gene targets, which covered 17 bacterial species and or genus, 9 viral targets and 2 fungal targets. On the respiratory and mucosal side for swabs, the Luminex assay covers 21 genes, 19 of which are viral targets, including flu A and typing, and any of the combined rhinoenterovirus outputs we further differentiated by PCR. So in total, we tested 5,049 blood samples and just shy of 3,200 swabs. In terms of QC and inclusion criteria for the diagnostics analysis, we included only European cohorts, only samples taken on admission, and only samples from a patient's first episode. So patients weren't presented multiple times within the data set. What we were left with was 3,009 QC'd blood samples from cases and 544 whole blood controls, 1,930 QC throat swabs and 206 controls, and a nice overlap of 1,779 cases where we had blood diagnostics and respiratory diagnostics completed. So just starting with this slide, just to demonstrate to you the power of PCR comparative to gold standard culture techniques. So on the left block, we have some established bacterial targets. In the green bars is where each bacteria was only detected by culture during the diagnostic workup. The blue is where we have a matched culture and PCR results, and the orange is where we had a retrospective PCR result only. So what's apparent is not only the lack of overlap between the techniques, but the sheer amount of PCR only detections. And if we break these down using the PERFORM phenotypic classifications as described in the earlier talks, so bacterial, definite bacterials on the left, going through to the unknowns, and then out towards, through the probables, out to the definite virals on the right, we did have an increased frequency of these PCR only detections in the bacterial groups. And what this suggests, certainly for the probable and syndrome groups, is that PCR is detecting organisms in patients that look like they might have a bacteria, but this wasn't actually detected at real time. So moving on to summarise some throat swab diagnostics. So we found that 46% of cases were positive for one or more respiratory virus, compared with 19% of controls. And these charts just show you the breakdown of pathogen detections by organism within the total number of detections. So rhinovirus was a predominating organism in both groups, with an overrepresentation of rhinovirus in the controls. This may be consistent with the concept of rhinovirus being asymptomatically carried in otherwise healthy individuals. Following from rhinovirus, the next most frequently detected targets were adenovirus, enterovirus, and bocavirus. This is striking because these are pathogens that may not necessarily be so readily screened for in a hospital setting comparative to other protagonists, such as influenza and RSV. So this has implications for cohorting and infection control. The next most frequently detected pathogens that were more represented in cases than controls were influenza and RSV. So this plot just shows you the percentage of each of the PERFORM phenotypic groups where we found one or more respiratory virus. So as you might expect, we found more viruses within the viral groups, pushing 60%. But what's most interesting is that in the bacterial groups, we found between 35 and 45% of cases, we also found a virus. So moreover, if we break these detections down into pathogens, there were some viruses that were significantly more represented in the definite and probable bacterial groups than in the control group, so bocavirus, adenovirus, enterovirus, and rhinovirus. So what this means is that if we find a bacteria, it doesn't necessarily preclude the presence of a virus, which may or may not have preceded the bacterial infection. But conversely, if we find a virus, it doesn't necessarily mean that bacteria is present, and thus that antibiotics need to be withheld. So the two cannot be seen as mutually exclusive. So to explore the relationship between bacterial and viral co-infection a little further in terms of presentation, we did an analysis where we looked at the duration of symptom onset prior to admission in various groups that received our retrospective diagnosis. So what we found is that where we detected a bacteria only, the duration of symptom onset was significantly shorter than if a virus only was detected. Moreover, where a bacteria and a virus were found together in co-infection, the pattern looked much more like the virus-only group, so an extended duration. There are also a lot more outliers in the virus-only and co-infection groups, with patients having many, many days or weeks of illness. So what this potentially means is that it might be evidence that viral infections are preceding bacterial infections, as is the way that is described for influenza preceding a pneumonia, for example. So moving on to blood diagnostics. So we found a staggering 65% of cases had one or more blood viruses detected, and 76% of controls. Now this was somewhat alarming and counterintuitive on first inspection, but if you break down the detections by organism, we found that HHV7, HHV6B, and EBV, so the herpes virus family members, were all significantly more represented than the other viruses in both the cases and controls group. If they're removed from the analysis, we found enterovirus, adenovirus, and CMV were significantly more represented in the cases group than controls group, with the exception being parvovirus, where we had quite high representation in the controls group. But this may be due to the tail end of a seasonal outbreak, because the majority of these detections were from one site and were all within a 2-month period. And parvovirus viremia following acute infection can last for many weeks or months after the infectious event. So how do we interpret this distribution of virology? So for EBV, HHV6B, and HHV7, the majority of positives were at very low viral load, and these are not conducive with an acute infection. But there is no established reference range of viremia for what constitutes a normal range or what is a threshold for clinical relevance. But because this data set is so rich and we have substantial controls data, we could explore this a little bit further. And what we found is that at the low viral loads, so around the 25th percentile, there was no difference in terms of odds ratio. So you were no more likely to find the virus in a case than a control. But as viral load increases, you become more likely to see these organisms in cases and controls. So for EBV and HHV6B, this became highly significant at the level of the 95th percentile of viral load, but this was not the case for HHV7. And conversely, at the low viral loads, you're more likely to find it in a control in a case. And we're not entirely sure why this might be, but we can speculate that an inflammatory response into an alternative pathogen results in an increase in inflammatory mediators such as interferon and other cytokines, which suppresses your HHV7 basal replication to the point where viremia can no longer be detected in the blood. So these charts just show the percentage of each of the PERFORM phenotypic groups with one or more blood viral detections, with the chart on the left including all of the data, and the chart on the right excluding data below the 95th percentile for the herpes viruses, as I've previously described. So on the left, as you can see, very high number of positives in all groups, no distinction between cases and controls, and no distinction between phenotypes. But when the background noise is removed, we see a distinction firstly between the controls and the cases, a bias towards the viral phenotypes, but still 15 to 20% of the bacterial phenotypes having a confirmed virus detected. So if this possibly is due to either a bacterial and viral co-infection, and we're just not detecting the bacteria, or it represents a virus masquerading as a bacteria. And we know this is plausible in the post-COVID era, where COVID can throw a variety of symptoms, including high CRP. And there are other members of the consortium that have examined this phenomenon, and we find this in our data set. So this is an example of adenovirus, where we have high CRP up the y-axis. Here we have an adenovirus, a group where adenovirus only was detected, and on the right we have adenovirus co-infected with a bacteria. And what you can see is the range of CRP in the adenovirus only group is extremely high, with a high proportion over 60. And so we're really looking forward to mining this data set for other organisms in terms of comparing the diagnostic results and looking at the biochemistry and the syndromic presentation in order to identify some significant patterns, associations, and correlations. So I'd like to summarize and just say that molecular testing clearly adds significant diagnostic value to the PERFORM dataset. We frequently find bacteria and viruses together, and the two cannot be seen as mutually exclusive phenomenon. And I'll just describe this plot here, where we have the phenotypic groups along the bottom, represented as percentage of group, so 100% of group at the top of the bar. It just really nicely shows a picture of clinical diagnostics as it is today. So in green we have bacteria-only infections. So from definite bacteria on the left, we have this nice V decrease in probability down to the unknowns. In the blue, we have viral-only detections, and so again a nice V actually encroaching over into the bacterial side. In purple, we have co-infections. And in red, we have this enormous chasm of unknowns, where despite a thorough clinical workup and pan-diagnostic screening exercise with advanced molecular techniques, there are still no organisms detected. And if we add the proportion of this unknown group that received antibiotics, we can see the proportions are extremely high. So on the bacterial side, over 90%, and from 25 to 50% on the unknowns to the definite virals. So this is consistent with previous talks this morning, which have described appropriateness of antibiotic use. And overall, this emphasizes that there are shortcomings in our current diagnostic strategies, and the place for a personalized medicine approach. So we're very excited to apply this diagnostic data set to the other work packages in PERFORM, and to take this work forward into diamonds. So I'd just like to acknowledge the team at Micropathology, our colleagues at Imperial who have been responsible for this analysis, and all PERFORM colleagues, particularly those who've handled the samples.
And maybe I can start with Mike. Can I ask a question? You've shown your the talk that you can't assign a diagnostic group to 80% of the patients in PERFORM. Are you confident that it's really going to change if we have new RNA or protein diagnostics that are developed from the PERFORM and DIAMOND studies?
Thanks for a really important question. I think in any research, one can only be as confident as you have data to confirm your confidence. And I think what we have shown from the previous studies on bacterial and viral, TB, Kawasaki disease, each disease we've looked at, we've found a signature which predicts those patients who've got that disease with high accuracy. What we don't yet know is whether that will apply to the groups of patients that we haven't got a definite diagnosis. So the approach has been find the gold standard for each disease and identify the signature that predicts that gold standard. For the groups of patients that we can't classify, we have an expectation that the molecular signatures will do it, but that is why we need a research program of this scale to give us the hard data to show that that's true. So I'm confident that we will predict the gold standard, and I'm hopeful that it will also predict the group in between, but that's why we need to do the research.
And Mike, do you think that we'll be able to apply biomarkers that are based on discovery in blood to diseases that aren't strictly infectious or inflammatory? Because the aim is to replace that fat ICD-10 or 11 book with a molecular test. And so we need to think about other non-infectious and non-inflammatory conditions. Will it work if we're using blood?
Yeah, I think, again, a really important question. And again, to say we only know for certain what we've got data to prove, and we've only really looked at bacterial, viral infections and inflammatory diseases. When we come to malignancy, to organ-specific diseases, we don't yet know. We have a high expectation that there will be a blood signature because the immune system reacts to everything. And a remarkable finding is that for very mucosally located infections like influenza and RSV, which are purely on the mucosal surface, there is a striking blood signature. So it would seem likely that the immune system is surveying the function of all organs, and we will have signatures for non-blood-based diseases, but that remains to be seen. And I don't think we should try and speculate beyond where we've got data to confirm our speculation.
Okay, thanks, Mike. I'm going to ask a question to Federico. Federico, you mentioned the fact that you're seeing a different pattern of disease in the PERFORM data than we had in the Euclid data, which was essentially a study that was running for the previous 5 years, a bit of overlap. Do you think this is down to changes in vaccination practices across Europe? Is that enough to explain it?
Well, this could be a really important factor, but of course, this is a multifactorial thing. It can be related to the fluctuations of microorganisms, changing polysize and several aspects. But indeed, if we look at the specific pathogens in the Euclid's cohort, meningococcal disease, pneumococcal disease were the predominant ones, even if we were making a target one, and now they are in the top down of our current list in PERFORM. And the real change have been the inclusion of new vaccines like the meningococcal B1, widespread use of ACWY against meningococcal, or even the new generation conjugate vaccine. So I think that it cannot be only explained by that, but it's a strong contributing factor.
And can I ask a question from the chat? What was the incidence of co-infections in PERFORM?
Yeah, well, if we take into account that this only according to standard practice, it was in total at 6%, around 6% of all included patients. But take into account that is 6% of the total cohort, but in that cohort, 65% had not a single microorganism identified. So the proportion might be higher if you only take into account the percentage of co-infection amongst those that where at least a pathogen was identified. But for the total cohort, it's around 6%.
Okay, thanks, Federico. I've got more questions to ask than I've got time for, so I'm going to move on to ask Henriëtte a question, please. So the question is that whether vaccination status affected the risk of bacterial lower respiratory tract infection. Did you have data on vaccination status in the MOFICHE data that you could answer that question? And do you think that this is going to be a relevant factor to take into account if you're building disease prediction models, that you have to take account of the vaccination status of the individual, because it will obviously change their susceptibility to different diseases?
Thank you for the question. Well, we don't have vaccination status of the individual patients in the MOFICHE database, but we did a survey for the different countries to get insight in the vaccination program, and they all had vaccination against pneumococcus and meningococcus, but it's not on the individual basis. And well, I think if the vaccination status change, then well, I wonder, then there is still a change in bacterial infections. So the cause of bacterial infections might change, but the largest number of viral causes that are still identified with the decision rules. So I don't think that there will be a major change in the prediction rules, but of course you always have to update it if there are changes in these programs. And we can do that if you on a regular basis collect these kind of data, and in the Pediatric Immunology Group of Europe, Root is also leading that. They're collecting now ED data for the COVID, but I think it will be a good idea also to do this for an ongoing study. So then we will learn about it.
Henriëtte, can I have another question, please? So I have to slightly turn away from the screen when I see your slide on antibiotic use in different countries in the PERFORM consortium, and the top 3 users of antibiotics in the consortium were all the 3 UK sites, which is slightly embarrassing. But why is this? And I always thought that, you know, we use more antibiotics, we get more antibiotic resistance, but actually I'm pleased to say that the UK is not the top of the table for AMR. So does this mean that we shouldn't try and understand AMR in terms of antibiotic use, or is it just something about our hospitals where we're particularly using a lot? Do you have any insights into that?
Well, I think you can give your answer yourself, of course, and we discussed that also previously, and it's well, I think the most antibiotic prescriptions are from the GP, from the community. So I think they have the largest influence on the resistance. And also the veterinarian antibiotic prescription will influence the resistance pattern. So I think that it's a larger influence on the antibiotic prescription. And well, I think in the hospitals, we all think, and well, it doesn't matter if you are on top of it or if you are in the middle, we are still describing antibiotic for viral diseases. So I think it will be, well, in my hospital, it's helpful to discuss when you start antibiotics and when to withhold it. And there are a lot of junior doctors who are doing this work. So they describe it's not the seniors who are thinking that they follow the guidelines. So there's a gap, I think, between practice, implementation, and theory. Okay. For all hospitals.
All right, I'm going to move on now to the last speakers from micropathology. And there's a question that's there at the top of the list about the fact that when you're looking for bacterial pathogens, you find that the most common bacterial pathogens are also bacteria that can sit there quite happily as commensals, and detection of a bacterium that can either be pathogenic in some circumstances or commensal organism in other circumstances always leads to a question of whether in the case that you're identifying it, is it responsible for your illness, or are you just detecting something that happened to be there? And how do you move from detection to infer causality when you find a bacterium that may in some cases be pathogenic, but not when you find it in other cases?
I think this is an interesting question, because we're faced with the problem of trying to tie up our molecular diagnostics with the clinical information, and that's critical. But what we are looking at really is a change in immune status of the patient. So what may be a bacterium one day sitting harmlessly or potentially in the blood for a very short time from, say, a dental appointment or from just biting your teeth. And then the next day that can become a pathogen. So it's a very difficult question to answer. And that's why we are so keen to get all the clinical information from the entire cohort at the same time as looking in the blood and in the respiratory tract, to try and tie the whole lot together. So it's not a question that is yes or no, it's a question of maybe.
Okay. And
sorry,
go on.
could I just add from a technical perspective, the viral load or bacterial loads that we find are going to be absolutely critical in terms of interpretation. There aren't established ranges out there in a lot of cases. For the virology, we've been able to produce standard curves, and so we can get absolute viral loads, which is very useful. But for the bacteria, we don't. We only have CT values for the PCRs, which are obviously arbitrary. But even so, it's certainly something that we need to apply to this analysis going forward.
I think one of the things that would be very useful here is if we could get a second sample from some of your patients, and I know that's logistically very difficult, but that would give us a much better handle of what's happening in these cases, whether the bacterial load disappears and it's transient and of no significance, or whether it is actually climbing and we see it again in the second sample.
Thank you. Thank you very much to the speakers, and thank you for all the participants in bearing with us and the fact that we've gone over time.
And now it's my pleasure to introduce Myrsini Kaforou. She is a genius from Imperial College of London and a good friend, and she will talk us about the identification of host blood RNA biomarker signatures to diagnose bacterial infections. So Myrsini, the floor is yours.
Thanks Federico. Hi everyone. It's a pleasure to be here and talk to you today about our efforts to identify host RNA biomarkers from the blood to diagnose bacterial infection, and tell you about what we're doing in PERFORM, but also what the vision is in Diamonds. So as you've heard this morning, in the past decade, we have contributed to the paradigm shift in infectious diseases, that instead of trying to identify the pathogen that may be lying in sites that are not accessible or in numbers that cannot be detected, we are looking at identifying patterns in the blood of the patients that are specific enough to allow accurate disease diagnosis. And we have shown that these patterns are so specific that they can allow us to distinguish various diseases. So how we do that? We look at RNA from whole blood, and you've heard all about the recruitment of the patients. So the blood goes into collection tubes, and the lab teams purify and extract the RNA, and we then quantify the gene expression in either targeted or untargeted manners. So we can look at specific genes we're interested in, like here in this figure, or we can look at a much bigger set of genes in a hypothesis-free way, measuring simultaneously thousands of genes using microarrays or RNA sequencing. And this is where our role starts. So we look at first doing data quality control and pre-processing, then we follow up with feature selection, and we identify and implement models that are predictive and diagnostic. We then evaluate them in validation cohorts. And it's extremely important to make sure that the biomarker models are both interpretable and translatable and can be used in the future in the clinic. So I'll tell you a little bit about the work that led to PERFORM. And one of the major question, the thing we have convinced you that we don't have a very good answer just yet, is how do we distinguish bacterial from viral infections? So in 2014 at Imperial College, we used this approach, and we managed to look at the blood of patients in a cohort of well-phenotyped case control manner. And we looked at blood and measured genes on microarrays. And as you can see on this figure here, we have genes that are upregulated and downregulated in bacterial and viral infections. And you can see that there are various genes that go up and down and are switched on and switched off. But if you want to use those genes in a diagnostic test, you need to eliminate the number as much as possible. And we identified, we developed a method, an in-house method called forward selection partial least squares, where we eliminate this number of genes down to 2 in this case. And this method was developed by Professor Lachlan-Coyne. And we managed to identify the gene signatures using a discovery cohort of 240 patients. We split it into a training and test set. And we, as you can see on the plots here I'm showing the disease risk score. You can see how the patients are discriminated. You can see the area under the curve being almost perfect. We have an area under the curve of 96%. And we further validated the performance into 2 different data sets, a publicly available data set in PBMCs from Ramillo's group and our own previously published data set. And we see how the signature retains its sensitivity and specificity. But most importantly, we also wanted to see how the signatures perform in the unknown group. And we were very happy to see that the probability of bacterial infection calculated based on the signature matched the level of certainty that the clinical teams had assigned for each patient. And you can see how the disease risk score, which we term the probability of that the 2 gene signature gives us, matches very nicely with the clinical perception. And based on this classification, we hope that we can give guidance on administration of antibiotics for these particular groups. And I think it's really important to highlight here that all these patients, or the majority of them, 95% of them, took antibiotics. So how generalizable this signature is? At the same time we were publishing this study in JAMA, there was a similar study that came out in febrile infants, and we tested the signature, and it gave us very similar performance for the proven bacterial and proven viral groups, as well as in the indeterminate groups in the middle. And this was the work that formed the pilot data set that we used when we wrote the PERFORM grant, and I'll tell you a little bit about what the transcriptomics aims are in PERFORM. So in PERFORM, we want to identify the best markers for bacterial infection using RNA-seq data from a cohort of well-phenotyped definite bacterial and viral patients. And this cohort that we used, it's from the previous EU study that we were working on called Euclids, that recruited patients with life-threatening bacterial infection in Europe. And then the other aims were to make sure we validate cross-platform and cross-sample the signatures, but most importantly, deliver those markers to the product development work package in order to return them back to the clinic. So a few things about the resources we're using to answer those questions. We're looking at multiple data sets, and we want to identify markers that are as robust as possible. So we are using RNA sequencing. We're also looking at publicly available microarray data sets and using other technologies that are more friendly for being used at the clinical front, like nanostring and RT-PCR. And I'll just tell you a few more things about RNA sequencing. So as I mentioned, we're using RNA-seq data from the Euclid study, and also have brought in samples from various friends and collaborators around the globe. And we have split the data into batch A and batch B for lab handling purposes, but also it's quite convenient because we can discover on one batch and then validate on the other batch in order to make sure that the signatures are robust. A few things about the sequencing. So we're using whole blood RNA sequencing. We use ribosomal and globin depletion, and we're aiming at 30 to 40 million reads. And Dominic, as part of his PhD, has developed and mastered the pipeline for the analysis. which is quite conventional. We're using conventional steps. And please feel free to contact me if you want any details. I'm not going to go into much technical details at the moment. So we're looking at the bacterial versus viral comparison for the RNA sequencing data. And as you can see here on this volcano plot, we have candidate markers. So on the right-hand side, we have candidate viral markers that are upregulated in viral infection. On the left-hand side, we have bacterial candidate markers that are upregulated in bacterial infection. And you can see that we use a log fold change, a cutoff of 1.5, absolute cutoff of 1.5, to make sure that the findings would be translatable across different platforms. But also very importantly, we are also revising the question. Before PERFORM, we were looking at identifying a signature that discriminates bacterial from viral infection. But we feel that this is rather a closed way of asking a question, and it would leave unassigned patients that would not fit in either groups. So what we're doing now in PERFORM is that we're comparing bacterial infection, trying to identify patients with bacterial infection versus all other possible causes. And I'll show you the preliminary signature that we have just discovered on the batch A on half of the patients with RNA sequencing done. So we are looking at 500 patients in the relevant groups in the discovery cohort, and we use a method called LASSO to identify the transcripts, and then we refit those coefficients in an optimal manner using REACH. And for the first time, we're implementing and using a cost of misclassification penalty. So we want to make sure that patients that would have poor outcomes and they would deteriorate if they're not identified, like severe bacterial infections or bacterial infections in general, are not misclassified. And we implement that in the discovery of the signatures. And by following this pipeline, we have come up with a set of 18 genes that were identified and can distinguish bacterial from all other etiologies. And you can see here how the signature performs. So we're looking at the bacterial group, the definite bacterial group, and all other groups. Definite bacterial group with higher scores, higher prediction of being bacterial infection. And we're seeing the ROC curve here on the right-hand side, and we have an area under the curve of 84% for bacterial versus viral, but also quite importantly, we have an area under the curve of 88% for the comparison of bacterial versus all. If we were to zoom in and think a little bit about the pathogens in the definite bacterial and the viral groups, they were representative and they reflect in a profound way the recruitment done in Euclid's. So there are some pathogen groups that are dominating the picture, and for that reason, we're also using publicly available gene expression data to complement the findings and make sure that they are as robust and as reproducible as possible. So we're lucky because in the RNA-seq world and in the microarray world, when you contact a study, you need to make the data publicly available, and we go and mine this data to come up with additional markers. And very importantly, as of last week, we have done RNA sequencing in the PERFORM patients that we heard about this morning. And we are managing to fill out some of the gaps we have in terms of pathogens and look at a very complete picture for bacterial and viral infection. And also, we're in a privileged position to have the first patients with COVID-19, the first pediatric cases with COVID-19 and SARS-CoV-2, as well as Myrsini being sequenced at the moment, to make sure that any findings of PERFORM and diamonds are timely and are relevant and can answer questions that the new pandemic is posing. And in the last 3 minutes of my talk, I'll tell you what we are doing in diamonds and what we're hoping to achieve. So decoding and diagnosing the febrile child, we've been framing it as a binary question. Is it bacterial or viral? Is it bacterial or anything else? What we're trying to do with diamonds is to ask and answer this question in a more realistic, real-world way. So we're trying to say what this patient that the clinical teams have in front of them is suffering from, and we're trying to assign them patients into different classes. So do they have TB? Do they have an inflammatory condition, Kawasaki disease, cancer maybe? Do they have viral infection, but also which virus they're infected with? Do they have bacterial infection, but also which bacterial they're infected with? And we're using the same publicly available gene expression dataset I just talked about, but also we've enriched it with other categories. So we're looking at definite bacterial patients, definite viral patients, inflammatory controls, Kawasaki disease, TB, as well as malaria. And we used 75% of the data to train the algorithms and 25% of the data to test. And we're also correcting for class imbalance and misclassification to make sure that the difficult classes and the classes of patients that would deteriorate and would face life-threatening disease are classified correctly. And then we fit a similar model, lasso and refit. So a few things about the preliminary findings. We have 150 genes that constitute the classifier, and they can assign the patients into 6 broad classes: bacterial, viral, inflammatory, malaria, TB, and Kawasaki disease, with a remarkable accuracy. But also, and we were quite surprised when we saw that, pleasantly surprised, we were able to classify the patients into 18 detailed level classes based on those 150 genes that were down to the pathogen or specific disease level. And I'll show you a few row curves here to highlight this remarkable performance. So at the broad level, we're looking at AUCs of over 95%, and this is the test set that we used. And you can also see how we can replicate this classification in a detailed level. So we can classify the patients based on their gene expression profiles into those with adenovirus, E. coli, enterovirus, and all other pathogens. And there are some groups, some pathogen groups were not doing as well, but again, there's a lot to be said about finding rhinovirus in a child's nose and how causative of the disease that can be. Very briefly before I finish, I think one of the most important aspects when you work with gene expression data is to make sure that the findings are reproducible in different cohorts, and we performed cross-platform, cross-cohort validation using the RNA-seq dataset collected in Euclids and sequenced with PERFORM. And we saw that with a smaller set of genes, because not all genes were measured with RNA-seq, we were able to, again, classify the patients quite accurately in the broad and detailed disease classes. So what we also saw is that we don't have, that the accuracy of classification is very dependent on the sample size. And for the patients that we had enough of, the classifier was behaving much better, and the classifier was able to identify them. But not the case with the disease groups we didn't have enough patients from. So this is exactly what we're trying to do with Diamond. So with Diamonds, we're trying to recruit the patients we're missing in order to have an exhaustive classifier. We're looking at undertaking a large-scale transcriptomic study and sequence additional 2,000 patients and combine them with the existing whole blood transcriptomic profiles we have in order to discover and optimize the diagnostic signature that we have termed personalized molecular signature for diagnosis. And then validate those findings with nanostring, RT-PCR, and at the next step, roll out the test as a tool in the clinics. And we are hoping to fill out the picture, and rather than just looking at bacterial and viral host response, look also at pathogen-specific responses, inflammatory responses, and parasitic responses. And one of the ways we can see this being used is, for example, I'm showing here some real world data. So these are patients in the study, and you can see the high level gene expression classification tells us that this patient has malaria, and the low level the same, and indeed this patient had malaria. For the next one, they have high probability of being viral infection. and the lower probability, the lower level tells us they have flu, and indeed they had flu. But most importantly, we can also look at co-infections, viral co-infections in this case with flu and RSV, or bacterial and viral co-infections with pneumo and flu for this particular patient. So I'd like to conclude by saying that, yes, indeed, we have minimal gene expression signature from whole blood that can distinguish bacterial from viral infection, but also bacterial from other diseases. I can't stress enough how important cross-cohort and cross-platform validation is. The patients that we use in our studies and that we include in our studies need to reflect the real-world diagnostic questions, and our biomarkers are only going to be as good as our recruitment and as relevant as the questions posed. And we really hope that the multi-class classification works in an exhaustive manner, and we're going to test it and hopefully roll it out by the end of the Diamonds project. Thanks to many people, thanks to the whole consortium, and I'd particularly like to acknowledge the bioinformatics team at Imperial. Thank you very much.
Thank you very much, Myrsini. Excellent presentation. We move now forward to the next one, and now we have another asset within the PERFORM and Diamonds team. He is Taco Kuipers from the Netherlands, and he will give us the proteomic side of the equations. He will talk us about the identification of plasma protein biomarkers to distinguish bacterial and viral infection. Taco, the floor is yours.
I just want to take you to the identification of a novel protein biomarkers set using a multi-platform approach, using the data from Euclid and PERFORM, and going, of course, into the diamonds, as already alluded to earlier. So as a background already alluded to, is that the traditional biomarkers used in clinical practice to distinguish bacterial and viral infection, like CRP or procalcitonin, have their known limitations, and therefore it was necessary to think about how to identify new discriminators for such infections and look for protein biomarkers that could be used clinically as well. Reasoning that indeed pathogens have their effect, a different effect on the human host, especially the immune system, depending on whether it is a viral response or a bacterial response that we are at least focusing at the moment. So this infection, of course, leads to changes in the protein expression, and those changes could, of course, be leading to a diagnostic test, which is observable through studying the host proteome. And whether there are discriminatory patterns to be elucidated and can be used as biomarkers, of course, the aim of the study. So these biomarkers have led to a start looking up the proteomic data sets generated earlier from samples from the former Euclid data set by mass spec, by proteome profiling, and other data sets. And there were lots of quality controls, of course, in the meantime, done not only on the clinical data, but of course also on the sample data as such. And the very preliminary exploration of such proteins led to different approaches being unbiased and from candidate approaches, as I will explain, to find out whether there's a signature that could discriminate bacterial from viral infections. And then, of course, since then, during the PERFORM program was ongoing, novel protein biomarkers were included to validate. So the whole process for the unbiased approach took the approach of using different data sets, different platforms, as well as different sample types. So for instance, here the different platforms used were the SomaScan, which is really a kind of a proteome approach, but targeted, an untargeted mass spec approach for two different validation cohorts. Sample types were serum or plasma, and the study starting off were from the Euclid samples, or later on the PERFORM samples, which was more inclusive. As you can see here, using the paradigm of definite bacterial patients and definite viral patients having been collected throughout the time were given here. And most common bacterial pathogens, as you can see, is the meningococcal and pneumococcal in the first two batches and different ones in the final batch, as well as for the viral pathogens, which were not only enteroviral and RSV, particularly in the early Euclid's data set, but also including influenza and adenovirus. All data sets were normalized with outlier patients taken out. The approach for the analysis, as already explained by Myrsini in the previous talk, was by differential abundance analysis using LIMA. That gives you long lists of proteins with differentially abundance of these proteins between definite bacterial and definite viral to come up with a good signature. And the selection of small signatures by feature selection using PLS, by an in-house algorithm developed at Imperial to identify a signature composed of the non-correlated features. And having this in 100 iterations done in a data set using different test and training sets. So for this biomarker identification, this is in a cartoon represented here by the SOMA scan and the two untargeted mass spec assays. We have set out for identifying these biomarkers using differential abundance analysis, LIMA, and which proteins are then significantly differential abundant in all data sets. Those were 15. And what are the top proteins from each data set, using that top 5. And then running a kind of a selection of these small signatures using this feature selection by PLS, having 100 times iterations done on the same data set using data and training sets. Which signature was most selected and which proteins were selected the most. And that gave us a kind of a top 5 of these. All together with the different sets, 35 proteins were collected, 18 going up in definite viral, 17 going up in definite bacterial. And here are the list that, of course, contain all the proteins that we could focus on as identified through a unbiased approach, as mentioned. So the experimental validation then, of course, took place by using an almost 25 protein candidates from these lists using different ELISAs and also Luminex immunoassays to validate these parameters derived from the unbiased approach. And this was including the different parameters that we already listed before. So the analysis and the validation took place by pre-processing, by log transformation, and by correction for the different batches and plates that we used. And as you can see in the principal component analysis, indeed, these data just separated nicely, and we also included the inflammatory syndrome, which I will not be talking about. The method for the validation analysis, again, was the feature selection by PLS, the logistic regression, and multiple regression using LOSU to build a kind of a prediction signature with and without CRP, knowing that CRP was one of the criteria to set the stage for the definite bacterial or the definite viral diagnosis. So having this done with 100 different test training splits, we have, with CRP included, a signature of 4 biomarkers selected the most out of these 100 iterations. And with the exclusion of CRP, we come up with 5 biomarkers of the ones that we started to test. By the logistic regression, we came up with 4 biomarkers, CRP included, or excluding CRP, we came to 2 biomarkers being significant. So here the signature performance for the unbiased approach, including CRP, having 4 protein signature with a very good area under the curve of 0.877, and excluding CRP with a 3 protein signature, it was slightly less, but still very, very good for sensitivity and specificity aspects. But we, of course, also had already started in parallel using a kind of a candidate biomarker approach or biased approach, using the different knowledge from previous experiences within the group, literature search, etc., etc. Starting off with a discovery cohort, as mentioned earlier, derived from the Euclid's studies, as well as 2 validation cohorts to see whether indeed using the same biomarkers as picked for as candidates from the Euclids were acting nicely in the PERFORM. And statistical prediction models were used based on these results identified by or generated by ELISA and Luminex. And we were in the same flow looking for severity markers. So this is just an example of 6 proteins that validated, like CRP itself, of course, but also GCSF, for instance, ST2, lipocalin, protein A3, and elastase derived from neutrophils that were really overwhelming and significantly more present in the sample from bacterial infection. So using this to build a prediction model by the discovery cohort by Lasso, using 25 biomarkers, we come up with 4 predictors with a very nice area under the curve of 0.94. But when we tested these in the validation cohorts, there was a clear underrepresentation of the viral infection, not so much in the validation 1, but definitely for the validation 2, it didn't work that well. So why are the 3 different cohorts so difficult to compare? Why are there such differences? Well, you might think, of course, of the differences in biomarker use over time. Some were left out over time and others were used as new biomarkers coming from the other analyses, the unbiased approaches, for instance. And there were, of course, also differences, and especially, for instance, the ICU admission in the discovery versus the validation cohorts, as you can see here. So the differences also apply to the pathogens across the cohorts, as well as the possibility, as we've heard in the morning session, about possible co-infections that we were not aware of. And for instance, the different pathogens across these cohorts is indicated here, starting off with a lot of meningococci and pneumococcal infections. And then for the validation 1 and 2 cohorts, the group A strep and Staph aureus, as well as the mixed and other and more mixed pattern in the validation cohort 2. And this was also true for the viruses, like the enterovirus and RSV, and especially RSV being the predominant one in the discovery cohort, while there were others more prominent in the validation cohorts. So then how to proceed and which protein markers to use from all these cohorts? Are there any valid markers in the meantime added and identified in the cohorts 2 and 3, so the validation cohorts? And can we use the former and the new markers to correlate to disease severity, but especially to discriminate from the start onwards between bacterial and viral disease? Using a Lasso model, including the novel biomarkers, using the last validation course, we indeed come up with 6 predictors. And this is also true for the CRPs having good ROC curves with an area under the curve of 0.90. So it needs further analysis and checks with the clinical data and the marker biology results. But as you can imagine, these 6 predictors were indeed nicely validating also the unbiased approaches. So we may believe that we are almost there. And we have developed a pipeline for the identification of these novel protein biomarkers and narrowed it down to about 6 proteins that we can use and apply to see whether they work and validate the other samples in the remainder of our PERFORM cohort. And especially the inclusion of viral biomarker was essential to come up with the final prediction model that seems to work fine. And there I want to thank also all members of the PERFORM and Euclid's consortium, and especially from the Imperial College, the hard work of Heather Jackson and Myrsini, and at Sanquin, Judith Sandstra, and the Redbout, UMC, Marine de Jong, and Jolene Cloer, as well as Clement Casals for the mass spec profiling in the beginning of this whole journey. So I want to thank you here and stop sharing. Thank you.
Thank you very much, Taco. Very nice presentation. Again, we will try to address the question at the end of the session. And now we move on to the next topic, and it will be Karen Brengel-Pesce from Myrsini that will talk about how to translate the host biomarkers into a diagnostic test. So Karen, the floor is yours.
Good morning, everybody. Thank you for the invitation. And I'm Karen Brengel-Pesce from Myrsini, and I will speak about the translation of RNA signature into a diagnostic test. So what we need in terms of clinics, we want to exclude with certainty a bacterial infection, especially in infants less than 3 months, and for the olders, we want to differentiate multiviral infection from bacterial infection. So in order to discharge the patient without antibiotics in case of viral infection, or to start quickly antibiotics, and further to hospitalize also the patient and guide the clinician for that. Today, we will present a rapid and sensitive test to discriminate viral from bacterial infection in the framework of the PERFORM project. So what we have in terms of host response biomarker, we have only PCT and CRP that are currently used at ED for children, but we know that they have limited performance, especially in children. And we have other and a lot of pathogen-driven diagnostic tests, especially conventional microbial technologies, but we have also rapid tests, even if they have not been often used. And we know that we need innovative diagnostic tool, and I will present what we did on the FilmArray system. The FilmArray is a simple, easy, and fast multiplex PCR platform. We need only 2 minutes of on time to launch the run, and the run time is about 1 hour from the sample in to result out. The FilmArray pouch is the device that allows the qualitative and semi-quantitative test, especially for pathogen detection. It's a syndromic approach, and we have many available panels to detect viral and bacterial infection and fungi also. And what we wanted to do is to adapt this FilmArray system to transcriptomic biomarkers. So our main role in the PERFORM consortium is to prototype a product that allows the discrimination between viral and bacterial infection. So for that, we know that we have different challenges to overcome: the design of the RT-PCR, normalization, quantification, and the main part will be to have comprehensive result and actionable result, the regulatory compliance for registration, and the market access in link to the product. So today we demonstrate the technical feasibility to use transcriptomic biomarkers directly from whole blood in the system. And we have a first version of a FilmArray pouch to discriminate viral from bacterial infection. This pouch contains 5 viral markers and 8 bacterial markers, and 3 housekeeping genes for the normalization. This work was done from the discovery part made by the Imperial College of London with the publication mentioned in that slide. And we did the technical validation from the conventional RT-PCR into the FilmArray system by screening more than 100 different samples. And now we have this first prototype available, and we did a design to evaluate the performance of those pouch. So we use a French cohort set up in the University Hospital of Lyon that included about 500 febrile children aged from 7 days to 3 years with definite and presumed infection. It's a prospective routine inclusion at ED department. And the classification of the infection was done by an adjudication committee. And we dissociate this cohort into a training set and a discovery set, a discovery test set, sorry. And after evaluating the combination of our markers, we evaluate the performance on a subgroup of the PERFORM study to limit the same age and the same viral and bacterial infection. And for that validation, we used 336 patients from the PERFORM cohort. So for the discovery French cohort, here we have the performance on the training set using the 12 transcript model, and on the test sub cohort, we obtained the same performance, meaning a robust area under the curve. And this AUC was also confirmed on the subcohort of the PERFORM patient. Sorry. So finally, the combination of the 12 markers has been demonstrated as stable and robust in 2 independent cohorts. So we know that one threshold is not sufficient. Is like for the CRP, we cannot choose only one threshold to guide the clinicians. So we think about classification of the infection in 4 categories, and to use the probabilities of having a bacterial infection, very likely and possible bacterial infection, and the very unlikely and high likely bacterial infection, meaning in that cases, viral infection. So to adapt this kind of classification, we use the test cohort in terms of performance assessment, and we can differentiate the very likely population, the very likely bacterial infection population from the very likely viral infection, so very unlikely bacterial. And using specificity and sensitivity of the test, we can classify and predict the infection in the children. And when we have a look on the performance obtained on the validation PERFORM subcohort, we have about the same performance and the same classification. Only the population of possible bacterial is a little bit increased, and the specificity is a little bit lower. But of course, this preliminary performance and the preliminary threshold have to be reinforced by pooling all the cohort, and of course also to use the total cohort of PERFORM project. In terms of performance, we evaluate the median value of the sensitivity and specificity. We also express the likelihood ratio to evaluate the performance in both cohorts. And depending on the threshold, we have a very good performance, especially for negative likelihood ratio to exclude bacterial infection, and very good LR positive to include and to diagnose bacterial infection. And when we have a look on the PERFORM subcohort, we have also very nice performance. And we know that those performances are better than the CRP ones. And additional testing is necessary to reinforce this performance. So the combination of several thresholds to define groups of probabilities seems more appropriate to express the result and to have an actionable result for the clinician and adapt the patient management. So in conclusion, we have demonstrated that the FILMARRY system is adapted to transcriptomic signature analysis. We have a first version of POCH to discriminate viral and bacterial infection in febrile children less than 3 years. We have 7 bacterial markers and 5 viral markers. We know that from the RNA sequencing performed by the teams of Myrsini, we know that we will improve those markers. And but of course, the interpretation model of the 12 transcript signature is robust enough in 2 independent cohorts, and even those first version is really interesting to go deeper and to evaluate performance in a larger cohort. Of course, the threshold may be refined by using different additional specimens, and the goal is also to use the PERFORM whole cohort as a prospective cohort, and maybe go further to allow discrimination of bacterial infection from viral infection, but also from inflammatory. And in the Diamonds project, we are excited to go deeper and to go further to improve this pouch, this first prototype of pouch, and to answer more questions than viral and bacterial discrimination. We want to add severity markers, of course, and maybe some specific signature for the main syndromes. I would like to thank all my team in the joint unit in the University Hospital of Lyon, and of course also all the PERFORM consortium, and especially the Imperial College, where the collaboration is very nice and very exciting. Thank you very much.
Thank you very much, Karen. Excellent presentation, and so important in the aims of PERFORM and Diamonds. So we are so encouraged by the advances that you have provided, you and all the team of bioMérieux. So we move now on to the next talk and final for this session before the Q&A part. And it will be, or it is my pleasure to introduce Shunmay Yeung. She's another essential actor in the family of PERFORM and Diamonds, and she will address the topic of cost and social factors in an introduction of a test. So Shunmay, the floor is yours.
So thank you very much. And I just want to say that I am presenting on behalf of a big team. So just in case I run out of time, thank you really to David and Manuel in the London School of Hygiene and Tropical Medicine, and of course all the PERFORM partners who are too many to mention, and this would not be able to happen without the funding from the EU. So my work package is really about trying to understand the relative costs, risks and benefits of introducing a new approach to diagnosing and managing febrile children in the different European healthcare settings. And it's composed really of 2 elements, the comparative health systems analysis and the cost effectiveness analysis. And there's lots of information that we've needed to feed into that. And I'm going to go through and try to explain what they are and why we're doing them. So starting with the first one, the scoping and mapping of febrile child case management pathways. So firstly, we wanted to understand how should what are we saying at the moment in terms of how should febrile children be managed when they come to a GP's practice or an emergency department? So we've created a repository of the guidelines for managing children with different febrile syndromes. And we conducted a review, and we did publish something on the guidelines for otitis media. We're particularly interested in what's the role of current point of care diagnostics and where would a new one fit in. Then we're actually interested in how our children actually managed. And so we've been trying to map the pathway of the child with fever through when they get a fever at home, where they go, and what happens to them at the different levels of healthcare. So, for example, in the UK, so what we're trying to understand is where are key decisions made and how might a new diagnostic test influence this? So say you have a febrile child, they should at first go to a GP unless they're very, very sick. And then if the GP is worried, they get sent to an emergency department. This is in the UK. They may go straight to the emergency department if they're very sick. Once they get there, usually they get seen by reception. They may go to the waiting area, be seen by a triage nurse. She'll use maybe the Manchester triage system to try and triage the child. Usually no blood tests are conducted at that time. The child will be seen by a pediatric emergency doctor who will do a clinical assessment, might decide whether to do a point of care diagnostic, whether to admit, and whether any invasive investigations are needed or not. The nurse may be the one who actually helps, for example, with taking the blood test and will be doing the vital signs. The child might then be seen by a pediatric doctor who then also does the clinical assessment and makes those clinical decisions. Professor Moll earlier described the MOFICHE study, which described what's happening in the various sites as part of the PERFORM. And in addition, we also did a study we're doing a study in the Gambia, which wasn't covered with MOFICHE, which is also trying to understand what's happening with kids going with fever at the moment. They go to a health centre. The nurse might use the IMCI, the Integrated Management for Childhood Illness guidelines, for deciding what to do. And as part of the guidelines, the malaria rapid diagnostic tests are critical. So if, malaria is still a major cause of death in kids in malaria endemic countries. And we've got a really good test. The malaria rapid diagnostic test is almost a perfect test in terms of it's very easy to use. It can be used by village volunteers. It's sensitive and specific in the clinical context. It's quick, usually about 15 minutes. It's cheap. It's probably about 40 cents or less. And it's specific in terms of being able to discriminate between falciparum and other species. So in my I previously worked a lot more in malaria and have done quite a lot of work on malaria rapid diagnostic tests in terms of what is their actual uptake and do they actually impact on what people do? So did healthcare workers use them when they were first introduced? So this is part of the ACT consortium work that I was involved in, where we were comparing what do healthcare workers do with and without the introduction of those malaria rapid diagnostic tests. And you can see generally before there was an increase and it varied across different sites. But when they used it, did it actually change what they did? Did they stop using antimalarials? Because there was the same problem with antimalarials as there is with antibiotics, i.e. they are used a lot on children who don't have malaria. And so this is a little bit of a complicated test, but we're trying to see without the rapid diagnostic test and with. And you can see that generally when children had a positive test, the number of kids getting, this is actually those receiving an antibiotic. Generally those with a positive test did get an antimalarial, and there was a decrease in the use of antimalarials in those with a negative test, but not down to zero. So another component of what we're doing is trying to understand what do healthcare providers, stakeholders, and children, young people, and parents themselves think about the current pathways and the potential for a new diagnostic test. So we've been doing interviews with doctors, nurses, and stakeholders so far in England and Netherlands, and hopefully in a couple of other countries. With the team in Newcastle, they've been doing work with young people, which has been really critical in trying to understand what do children themselves think and their parents in terms of the current pathway and the role of a new diagnostic test. We've also conducted a large online survey of paediatricians across Europe, both paediatricians in the community and in hospitals. to try and understand what's the availability of current point of care diagnostics and how are they used. And that analysis is ongoing. But what would we find now? So this is post-COVID, and I think there's, it really has changed the landscape in terms of rapid diagnostic tests. There's been a huge increase in the demand and the use of tests, and also a real increase in public understanding about diagnostic tests. I think before people wouldn't really understand, wouldn't really be interested or really be aware of things like the false positives and false negatives, and I think there's a high awareness now. So another component is the costing bit, and that's been, so we're trying to understand what's the current cost of care and how would that change. And that's been very complicated. I'm not going to go into that in any more detail. And this all is going to feed into a cost effectiveness analysis, which David Barth has been the health economist has been busy doing. And it's difficult because we're at a very early stage of a diagnostic development. And so a lot of we're doing modeling in a relatively data-free area. But we are using the data from MOFICHE, and we're trying to understand, using with the current practice, with the current signs and symptoms, existing testing results, what does the ED doctor think is the likelihood of bacterial infection? How are they then managing a patient in terms of admission and antibiotics? And what does that mean in terms of health outcomes and costs? And then on top of that, what will happen with the introduction of a new test? So we are trying to understand what will happen with and without antibiotics. What will happen with different types of patients? So we're really interested in the group of patients where a test might make most difference, because we don't have a good test at the moment and where there's lots of diagnostic uncertainty. For example, in the under 3-month febrile child and in undifferentiated fever in young children, but we're also looking at lower respiratory tract infection. Just to say that one of the other things that we are interested in, of course, is the impact of a new diagnostic test on antibiotic use and therefore antibiotic resistance. And as Jethro mentioned earlier, it is timely because it's a European Antibiotic Awareness Day today. We won't be able to model, it's very complicated to model what will the actual impact be, but at least we get an idea of what's the role of a diagnostic in that bigger picture. So really, I think the key messages are there's huge potential for new diagnostic tests, but the impact and the cost effectiveness of any new test is going to depend critically on the test characteristics, which group of patients it's used on, whether doctors actually choose to use it, and how much it influences their decision. And it will probably differ quite a lot at the different levels of healthcare and across Europe, depending on what current practice is. And as other speakers have said, it's going forward, we're not just interested in the bacterial versus viral question, but this idea of the different syndromes, and also on whether predicting severity. And we really need to focus on which patient group will it make most difference in, and those in which there's most diagnostic uncertainty. And so ending with my first slide, thanks owed to lots of people and the lovely family of PERFORM partners, European Academy of Pediatrics, who partnered us with us on that survey, and of course the European Union for the funding. Thank you very much.
Thank you very much, Shunmay. And now I invite all the speakers to join and show them up, and we will try to ask or try to address, if not all, some of the questions that we have received. So I will try to address them, but feel free, any of you, to jump into any of them. So my first question is for Myrsini, and this question is about, I lost it. There was a question because they are still going in and I'm losing them. Okay, yes. There was one question regarding the area under the curve values, and they ask if of the 136 gene cross-validation, the area under the curve is too low to be useful, and what do you think is an acceptable level of area under the curve to have a useful panel test?
Thanks, Federico, and thanks for the question. In general, I think the comparison is the standard we have and is being used at the moment. So anything that we discover either with the gene expression or the protein work that is better to what we have at the moment and the clinical teams are using at the moment can change the practice. So I think it's true that particularly for E. coli, Staph aureus and pneumococcus, we have lower performance in the cross-cohort, cross-sample validation. When we looked at that, it seemed to be heavily influenced by sample size. And if for these particular 3 pathogens, the sample size was quite small. So we hope that with diamonds and doing more sequencing from the performing patients and expanding those groups, the performances will rise. And in particular, because the genes that we see and we have in the 136 panel, they seem to be very representative of different components of the immune system. So we have genes that reflect the complement, IL-17, T cells, B cells, phagosome, interferon signaling. So we have a little bit of everything, and we hope that in combination, they would discriminate those groups as well.
Thank you very much, Myrsini. Taco, there is a question from you, and it relates to if the proteins are also identified in the transcriptomic study. And also, no, yes, that's the question for you.
Well, that's a very interesting question, of course. And to be honest, we just started to see whether there's a correlation between the proteome and the transcriptome within the consortium. So at the Imperial team is busy with trying to collapse all these data and see whether they correlate. It might not be necessarily true, of course, that a transcript is really going in parallel, being up or down with a protein marker, because it might be not derived from the blood cells itself. It might, of course, also be released from a cell being pre-packaged instead of being synthesized de novo, newly. So for some reasons, it might definitely not be the same pattern that shows you to be a good biomarker at the protein level or at the transcript level.
Thank you very much, Taco. There is I don't know if this is an impossible question, Karen. They ask about the estimated cost of the diagnostic test.
We have always this question. But today it's only a prototype, so it's difficult, of course, to evaluate the commercial cost of this kind of pouch, of course. Mm-hmm. But sure that the cost of the CRP and the PCT will drive also a cost of this kind of product if it will be commercialized.
Mm-hmm. Thank you very much. There is another question, and this is for Taco. Taco, how do you look at the stability of these markers after antibiotic treatment in biological samples?
Not at this stage. It is an interesting question, of course, whether these markers drop very rapidly. And also there, we must remember that some of these protein biomarkers, if tested, for instance, the IL-6, drops very, very rapidly within minutes, even after starting antibiotics, while others being produced elsewhere or not by a blood cell or maybe has a different clearance mechanism is rather stable. So signatures depend, of course, on the proteins being involved and in our prediction model. And as we do not know exactly whether they last for longer, we expect that the ones chosen are pretty stable, but I can't tell for how long.
Thank you. I remind all the panel speakers to jump into any of the questions, so I am addressing them to whom they are asked. I'm sure you can also add value to the answers. There is another question for Karen. Does viral bacterial prediction score correlate with viral bacterial load in the sample?
We don't know, because the cohorts we evaluated are in routine used, and we have conventional diagnostic test, and we don't have the viral load, so we cannot correlate the viral load and the classification.
Thank you. I have also some other questions. How has EU funding enabled us to make this different research approach to the febrile patient? Mike, maybe this is for you.
Thanks, Federico. Well, I think quite apart from simply the fact that there is no other source of funding that could have funded a project on the scale. No individual country, small project grant, or even large project grant would have brought together a consortium of this scale. And what I think it has enabled is, first of all, many of the diseases we are studying, while being very important, are rare at any one hospital. And by pooling patients from all the diseases we're studying from many different countries, we end up with large enough groups to be able to say something definitive about it. So the funding has enabled multi-country and multi-hospital patient recruitment, which is unparalleled from any other funding. The other thing that it has done is brought together the range of expertise we have within this consortium. So bringing together laboratories that are strong in proteomics, such as TACO in Amsterdam, strong in genomics, like the Oxford Sequencing Group and the Imperial Group, strong in informatics, and as well as the biotechnology companies and the diagnostic companies with micropathology. It's really created a multidisciplinary resource, which has let us approach one of the most important clinical problems in a way that we would never have been able to do under with the small grants or working separately. So I really just want to add what I know all the speakers have done, is to acknowledge to the funders the amazing appreciation and support that it's actually a 15-year funding that we've had from the EU, with our TB grant, then the Euclid's grant, then PERFORM, and then Diamonds. And each study has built on top of the last one. So I think the EU really needs to be congratulated as a vision of bringing researchers from different countries together. And quite apart from the scientific and the clinical collaboration, the long duration of collaboration has created trust and friendship. And science flourishes when we're completely open to share data with each other and with everyone. And this has been a unique contribution of long-term working of a group of people who've met regularly and are able to share ideas, share expertise in a completely open way. So I think this is really a time to just say a huge thanks to the EU for this amazing program of work and the support of people in so many countries. And thanks for that question.
No, thanks to you, Mike. And I think it cannot be more appropriate to what you have just said in the European Day of Awareness on Antibiotic Use. I think that Euclid's PERFORM Diamonds are precisely in the middle of that question, and our exhibition day for PERFORM Diamonds fits in the date, although this was not planned. We should recognize.
And if I can also jump in and say, it is also appropriate as the UK nears Brexit to say that whatever happens politically, the researchers and the clinicians in the UK will remain part of the European science community. And we hope that our government shows the sense in actually continuing to contribute to the European science and be part of it, because without it, we'll lose the wonderful collaborations that happen across Europe. So let's hope for some political sanity, and we certainly will be remaining collaborative and part of this group, regardless of what happens with Brexit.
We all are clapping now, despite we cannot do live as we wish, but we all echo what you have just said. I think there is an interesting question, and maybe it's for all, but also Shunmay can can also try to help us with this. And it's related, we are aiming for, or we are being able with the test to separate the definite patients with bacterial and viral, and we are able to, let's say, address the extreme points. But the real problem, let's say, or the real difficulty in our daily practice are those that are uncertain. No? So how can we approach that, and how can PERFORM contribute to really solve the more doubtful patients, those that even after the routine workup, we are not easily able to allocate them into one group or another.
Federico, maybe I can jump in and have a first go at that question, because I think it's the fundamental problem with any diagnostic test. It's going to assign a group of patients who don't have a severe infection, and it's going to identify a small group that do and that we have to immediately treat. And then there's the group that we're uncertain about. And I think just translating that and thinking about a busy accident and emergency department where many, many patients are arriving with worried family, with worried parents, and they're saying, is this something serious or not? If the test allows us to rapidly say, this is a group of patients that needs immediate treatment, and we have to immediately take onto antibiotics, onto investigation, and say that there's a very large group of patients, perhaps 80% of all the patients, who we can say, you're fine, you don't have a high risk of anything serious, we'll send you home. That will allow hospitals to focus more resource on actually investigating and observing a smaller number of patients. So I don't think we have to have a test that's 100% accurate in all areas of the patients. We have to have a test that narrows down the numbers of patients that we need to focus antibiotics and investigation. So I think the way that Karen showed the results of the film array, separating it into a red zone of, yes, you've got to act immediately, a green zone of you don't need further investigation, and a middle group of orange where we have to focus observation, could greatly reduce the workload and also the missed patients. So I think I hope that by grading patients by probability of a severe problem, we will be able to narrow down those that actually need antibiotics and investigation. But I know this is something that Shunmay has thought a huge amount about, and perhaps she can jump in.
Thanks very much. And I can see there's some questions from Sanjay and Gianos, which are actually in the similar frame. I think it's really challenging because I think there's different outcomes we're looking at. So for antibiotic use, if our aim is to decrease antibiotic use, then we have to recognize that most of the antibiotics are prescribed in terms of total volume, are prescribed in general practice or in ED. And most of the children receiving antibiotics aren't getting a blood test. And I don't think, and we have to think very hard whether we're saying that those kids should be getting an antibiotic, should be getting a blood test. So there may be another approach to get to the same outcome, i.e. decreasing antibiotics, which isn't a test. It may be around, better clinical prediction rules, as people have implied. Because are we saying that more children should be having a blood test, for example? In terms of, and I think the trouble is that it's the uncertain group that we don't have a gold standard for. So we don't actually, that it's really difficult to, because I think what clinicians probably want to know is it definitely not a child who's going to be developing, in terms of the identification of a severe bacterial infection. They want to know, is this child someone who's going to deteriorate if I send them home? And if I send them home without an antibiotic? So and are we going, and we have to have a test which I guess is good enough to convince clinicians to change their practice. So I think the early kind of going from the kind of almost the efficacy studies to the effectiveness studies under kind of controlled conditions is going to be critical. So when a new test is introduced, to actually give, to have the follow-up to kind of reassure us and the clinicians who are using it that actually it's safe to listen to the test. What happens if you if that child that you would have given an antibiotic to, you don't because you're listening to the test. You follow them up and you get that's what happened with the malaria. You know, that happened, I think, with the malaria diagnostic test. It was the use of the early use of it and the reinforcement that, oh, okay, actually that child who I really thought had malaria didn't have malaria, though the test was right. I can trust it a bit more. So I think that is going to be critical.
Mm-hmm.
Thank you.
Thank you very much, Shunmay. There is more questions. If we still have time, Mike, we can take
yeah, take one or two.
Okay, perfect. There is one specific on that any one of us can answer about if we are considering to look at these biomarkers specifically in the immunodepressed, in the immunodeficient patients. No? And the answer is yes, that we are specifically collecting patients in this cohort and doing serial sampling with the idea to challenge the biomarkers we discover in other groups in this specific population, and eventually to find specific biomarkers in this group. There is another.
Federico, maybe I might add, because yes, I think the question is indeed absolutely right at the spot, because if you go for an analysis using biomarkers, protein biomarkers versus transcripts, it might be very relevant to see whether the signatures remain the same. So an excellent question that we indeed intend to sort out in the coming time. And I think they might be leading to different signatures for the different high-risk patient categories if required. But that's something to fish out of the data.
Mm-hmm.
I suppose one thing to add to that discussion is that for patients with hematological or oncological problems or post-bone marrow transplant, we know that the RNA signature must be different because they're often depleted in blood count and don't have the cells that are making the RNA signature. I think it is worth asking the question whether the need for a test to rule out bacterial infection, at least as far as the decision of antibiotics or do you admit, is different, because the high-risk population, the benefits of antibiotics will far outweigh the likely harm, because of the high risk of, they're at much greater risk of bacterial infection. So we may need to make the algorithm for who gets treatment and how we use a test very different for the high risk population, particularly hematology and oncology patients. Shunmay, you?
Yeah. Yes, I think absolutely for all those reasons, and also going back to the antibiotic resistance question, I think it's really complicated, I think, and I think there's others who are better able to speak to this, but the relationship between who gets an antibiotic, what type of antibiotic that is, and the relationship between that and antimicrobial resistance, I think is quite complicated. But it may not be the kind of use of amoxicillin in primary care that we have to worry so much about. It may be really the high risk groups, the patients who are on PICU, the neonates, the high risk groups who are having second, third line antibiotics, which is really where the driving of drug resistance is. So being able to improve antibiotic stewardship in that group may have a disproportionate benefit in terms of antimicrobial resistance as well.
Thank you very much, Shunmay and all. There is one question, general question regarding that, asking about the point of care diagnostics, that many of them appear very promising at the beginning, but when they are evaluated in the clinical setting, they have very little impact on the antibiotic prescribing, related to many other factors that might influence the prescribing behavior. No? So we can comment on that, and they specifically ask us if we are planning to evaluate the PERFORM POCH on antibiotic prescribing.
we started this kind of evaluation to try to evaluate in missing bacterial infection what we have gained with the signature, and also for the viral infection treated with antibiotic. We did the work on the first cohort, the French cohort, and we have seen that about 11% of viral infection have been treated with antibiotics. And using the model of the 12 transcript, we can save about 60% of this viral infection treated with antibiotic. And the 60% of this infection have been well classified in viral. So normally we have to not treat with antibiotics. So sure that the work has to be done also for the whole cohort of PERFORM to have a better view on that. And I'm pretty sure that we will save some antibiotherapy, but that does not mean that the diagnostic test will be adopted by clinician, and we need to promote that to make this market access. But sure that even if we have good performance, that does not mean that it will well adopted.
Thank you. So I would really like to thank all the speakers for their nice presentations and in breakthrough concepts shared with all of us, and also for addressing the questions that we received from the audience, and apologize if we were not able to cover all of them, although some have been answered in the chat also. So Mike, I give you back the control of the meeting.
Thanks, Federico. I'm just going to share my screen. And I'm only going to show a few slides because I think everyone's been sitting at the Zoom screen for long enough. And I hope that all the talks have given an idea of the journey that we've been on. And I think when we set out in 2016 to design PERFORM, we knew that there were going to be big problems in assembling thousands of patients from across Europe, testing them for biomarkers, and trying to come up with a diagnostic test. And we had not expected that we would be facing a pandemic of the scale and magnitude and awfulness that we are facing. PERFORM will now end in June of next year. So we're in the phase of assembling all the data and trying to come to a final conclusion. And I think you've heard the exciting work from bioMérieux on the prototype test, but also of the extensive data, proteomic, genomic, that we've got. And along this journey, we recognized that simply distinguishing bacterial from viral infection was only going to answer part of the problem. And Diamonds was written based on the data we already had from PERFORM, but asking a broader question. And Diamonds was awarded just as the COVID pandemic evolved in all the countries in Europe and worldwide. And it's really a tribute to, first of all, that we were in an extremely fortunate position of having received large amounts of funding from the EU to study infectious and inflammatory diseases, that just as the pandemic was evolving, we could quickly refocus the efforts of the consortium on recruiting patients with COVID-19 and the childhood emerging inflammatory diseases. And I think it's a tribute to the groups working all over that we've already recruited over 1,000 patients during the course of the pandemic. It was extremely difficult recruitment. As you can imagine, hospitals were severely disrupted by COVID. And it was a huge effort to be able to enroll children and adults into Diamonds so that we could start studying it. And despite the fact that many university laboratories were closed because of lockdowns, we succeeded with a huge commitment of the Diamonds team in many different countries to have samples coming from these patients and to extract the RNA, extract the plasmas. And we already have the first data on the transcriptomic analysis of COVID and the first patients with the childhood inflammatory disease, which we only recognized in April and May of this year. So we will have those data being analyzed over the next few weeks. And this emergence of COVID and the childhood multisystem inflammatory disease has, I think, completely changed the picture of infectious diseases. I don't think the world will be quite the same after COVID and has arrived because of the new era of COVID-related inflammatory diseases. But Diamonds has been in a real position to contribute to this effort. And the vision of a European diagnostic transcriptomic library, which I briefly mentioned, is a task which I think will create an amazing resource to the scientific community and to people all over the world. And as I mentioned in the introduction, the idea is that we will be enrolling every disease that we have recruited into PERFORM, all the diseases we're recruiting into Diamonds. Once we've got the RNA, genome-wide RNA signatures from the RNA sequencing efforts, and also hopefully eventually a proteomic signature as well, we will end up with a library which will be deposited as an open access resource for the scientific community, which will have the transcriptome of every major disease, both infectious and inflammatory disease. And we are hoping that using the approaches that Myrsini outlined in her talk of information reduction, statistical techniques, we will end up with a small signature, which we've called a personalized medicine signature diagnostic, PMSD, the small signature that describes every other disease. And a visual example of it from a heat map of genes that are upregulated or downregulated, we expect that each disease will differ from all the other diseases by their unique genomic pattern. And based on that, we expect that we will be able to say one patient has culture negative sepsis, another has viral illness, another has Kawasaki disease, another has toxic shock syndrome. And obviously, as we have the signature of COVID and of the multisystem inflammatory disease, we will be able to work out which of the signatures we're seeing are represented by those diseases. So this is a very, I suppose, blue sky vision, but it is a vision which I think will become a reality because we've already got pilot data from PERFORM that the principle works. Each disease is characterized by a unique molecular signature. We also hope that we can translate these signatures into a new way of diagnosing all infectious and inflammatory diseases that present to hospitals around the world. And this is an ongoing task. It's going to take years. It's not going to happen immediately. Some aspects of it will be immediately translatable. So I want to end by, I hope we've given people who've joined the webinar some taste of what the spectrum of work is. It's a very broad spectrum. The data sets, while focused on diagnostic tests, are actually much more than that because they're going back to the signatures. We will have gene expression and proteomic data on almost every adult and pediatric disease. And these will be able to be interrogated, not just for diagnosis, but also to understand the biology, to understand drug targets. It will be immensely more valuable to the scientific community than just the question of diagnosis. So I want to end by again thanking this wonderful community of collaborators and friends who are now friends as well as collaborators. It's a real privilege to work with this group of people. I want to thank everyone who's listened in to the webinar, and we hope it's given a flavor of the work being done within this very broad-ranging community, from very clinically focused, looking at what happens to children in emergency departments, very broadly social and publicly focused by the cost effectiveness analysis, and very molecular and scientific in trying to understand diseases. So I want to thank everyone for listening in, and of course, again, thank the EU for making this amazing work possible.